So it's a pleasure to be with you here this afternoon. I appreciate the invitation. First, a shout out to the International Viral Hepatitis Elimination meeting, and John Ward and his team. This is its 10th iteration. 10 years is longer than most relationships, at least in Canada. So it's amazing that you've been able to get this far. I'd like to spend the next few minutes talking to you about some thoughts how to eliminate hepatitis C infection in vulnerable inner city populations. And I would like you to take note of my subtitle, A Question of Heart and Passion, because this will come back towards the end of my presentation. And these are my disclosures. And I should say that in Canada, we do not have high-level political support for hepatitis C elimination, but we do have a lot of partners. We have academic partners, clinicians, community, a lot of people in the public health realm, pharmaceutical industry, and this led to the generation of a document called the Blueprint to Inform Hepatitis C Elimination Efforts in Canada, a document that was led by Jordan Feld, and that laid out a number of activities that should be considered for hepatitis C elimination. Now, in parallel with the activities, it identified populations that should be prioritized for intervention, and one of these populations was those that use or inject drugs. So in Canada, we think this to be about 172,000 people. About 40% are infected. They account for 85% of the incident infections. Indigenous populations are particularly affected as they are at large within the population of Canada and would require specific attention. And we were probably making some progress in the mid-2010s, but then of course the pandemic hit, and these data taken from Naveed Janjua show in gray how we were doing. Hepatitis C treatment starts in British Columbia in 2019, and you can see that in 2020 we took a hit, about 50% down, and we're recovering from that, but that just adds to the complexity of the challenge that we must face in eliminating hepatitis C, particularly in the inner city. Now, this is meta-analysis from the Australian group that was recently presented at the INSHU meeting that looks on the x-axis at the prevalence of hepatitis C in injection drug users in different countries. And I've highlighted Canada there at about the 40%, which appears on both graphs. And you can see that this is well beyond just finding and diagnosing people. You can see that in the red box in Canada, we seem to have diagnosed 70% of those that are infected, but we've only treated 10%. So beyond just finding new cases, it's finding those that we've already diagnosed and that we've forgotten to treat. So the key to us is modeling, and I hate using this slide in a room where the chairs actually don't have legs, but think of this as a four-legged chair, is that the individuals that we want to engage, to them hepatitis C is not a priority. They have medical issues, social issues, addiction issues, untreated mental health issues, four legs of a chair. And as we interact with them, it is really what's important to you, which leg is important to you, and I will get to the Hep C eventually, and that's how we designed our program. So it's four legs of a chair and it's three pillars. The initial part of the interaction is engagement. I would like you to go from disengaged to engaged. I'm here to help. I want to make this multidisciplinary. We are in this together, and I want this to be durable. I'm not here to give you 8 or 12 weeks worth of pills, figure out if it worked, and then get out of town. We're in this for the long run. So it's engagement, multidisciplinarity, and durability. So the way this is operationalized is in the inner city of Vancouver, an entity called the Community Pop-Up Clinic. So we go to where people live, the places that they sleep at night, which I wouldn't necessarily call housing, but this is a discussion for another day. And we will meet about 30 of them in the course of an afternoon. We'll do point-of-care testing for HIV and hepatitis C. They will have immediate access to healthcare providers if needed. So the way this works is they initially sign a consent, as is brilliantly shown on the next slide, and then we will collect some information based on that consent. We'll do point-of-care testing for HIV and hepatitis C. If it's negative, that may be it, or they may choose to engage in care. We'll give them a gift card if need, as part of the program. They get a $10 gift card to go to a healthy fast food store called Tim Hortons in Canada. They can just get whatever they want for their $10. If it's positive, they may not want to talk to us, but now I know who you are and I know where you live. So I might be back. And if you do want to talk to me, I will talk to you, and you will get an appointment at the clinic, which is about a 15-minute walk about from the inner city. Or we have two new interventions. One is this well-equipped van that has an exam table, phlebotomy chair, the ability to do dressing changes. So they can go there, or we can bring the van back another day. So that's part two. And the most recent and exciting development is the new Vancouver Urban Health Center, which is in the neighborhood above from a pharmacy. So they can walk in there at their leisure and get care. And well beyond the hepatitis C, if they walk in, for instance, with an open wound, they'll see the nurse upstairs, a doctor will be involved, and they can have antibiotic cream and oral antibiotics in an hour. So they really get to understand that we're about them and will eventually treat their hepatitis C. So the CPC events between January 2021 and August 2023, 112 events, 3 to 4 hours per event. We screened 2,000 people. 70% agreed to the demographic survey. Prevalence hepatitis C antibody is 31%. 76% of them are viremic, and 81% of those that are viremic engaged in care are an average of 1 engaged in care for every hour we spend running a CPC. So looking at the 387 on the next slide, mine don't advance automatically. So the demographics, actually before I do that, the demographics, these are in their 40s. There's a bunch of women, a bunch of Indigenous, which is really important to us to capture the vulnerable Indigenous population. Many are not terribly well housed. Many are more educated than we thought, which is dealing with the prejudice in this particular population. Many have overdosed. We're in the midst of an opioid crisis, and they're using substances, mainly fentanyl. 81% smoke, and I put that on the table because all of the buildings where they live are non-smoking buildings, which is another challenge that we need to meet. Now on the next slide are my results. So of the 387, 326 started treatment, 60 are still engaged in care, haven't started, 1 died of an overdose. Of the 326, 304 completed, 18 are still on treatment, 3 lost to follow-up, and 1 other death. And of the 304, 286 are cured. 16 haven't reached the time point for cure, and 2 virologic relapses. So counting as failures, the 2 relapses and the 3 lost to follow-up, the success rate is 98.3% in terms of curing hepatitis C in the inner city. So this actually works in terms of engaging people in care, curing their hepatitis C. A different talk that I could give is about the opioid crisis. We have 6 to 7 deaths per day in our neighborhood from opioid overdoses. We've had 2 and 3 in 2 years in our cohort. So probably we're having other benefits than curing hepatitis C. To me, this is all about architects and plumbers. And I think that architects are needed. They design programs. They tell us how many people probably are living with hepatitis C, how many we need to treat to meet the objectives of the World Health Organization and the like. But you need plumbers to go out and do the work and measure what they do. We're not as good plumbers as they have in Egypt, but we're doing pretty good in our particular neighborhood. You really need the plumbers. Advanced slide. There you go. I have to talk to it. So the next step in our program, which is really exciting, is we're going to eliminate hepatitis C from the inner city. We've had discussions with the public health authorities, and they tell us in our neighborhood there's 1,200 or so left. How we got to that number, again, is another talk. But we can treat 25 to 30 per month over the next 3 years and wipe hepatitis C out of the inner city of Vancouver, which is our next goal. And this is where we need to really be excellent plumbers. And I think we have now the infrastructure to do this, and we would encourage other groups who treat the inner city and injection drug users to really follow this kind of a model. So we need to achieve the WHO elimination goals. I have great respect for all of the architects at the WHO because they've given us the objective that we need to achieve. To do it in this population, it is hardly ever about hepatitis C. It's about a bunch of things, one of which is hepatitis C. So let the architects tell us what is happening at a population-based level, and let the plumbers make it happen. These are the goals that we need to set, and we are fairly confident that we are going to be able to do this in the next 3 years. And how we are going to do it is this isn't normal healthcare. This isn't stuff that we learned in school. This is about having heart and understanding that this is a population that needs help, and having a group of people that are willing to come together as they have in Egypt and other places with the passion to make it happen. So this is what we need to do, and I thank you for your attention.